You take a small pill, and soon the ache begins to fade. It almost feels as if that tiny tablet somehow knew where the pain was hiding, but it didn't. Tonight, we're exploring what really happens when you reach for relief, the hidden language your body speaks, the electric paths that carry pain, and the chemistry that quietly rewrites it all. We'll trace the journey from nerve to brain, follow molecules as they drift through your blood, and uncover how a simple compound can turn the sharpness of pain into silence. Now take a slow breath. Let your thoughts settle. Together, let's explore the invisible science of how pain fades and how your body learns calm again. Chapter 1. Pain, the body's language. You've probably experienced pain as something that tells you to stop. The sharp hiss when you touch a hot pan, the dull ache after an intense workout, the searing toothache that ruins your sleep. But what if I told you pain isn't punishment? It's the body talking to you, blunt, urgent, and extremely practical. Think about the hot pan moment. You don't stand there and debate whether the burn is fair. Your hand jerks away before you even have time to think. That's the system doing its job. Tiny sensors in your skin, called nociceptors, pick up damage or potential damage and translate it into electrical signals. Those are real, measurable pulses racing along nerve fibers toward your spinal cord and brain. The signal sometimes triggers a reflex arc in the spinal cord that yanks your hand back instantly. Other times, the brain gets involved, interprets the input, and decides whether you need to rest, treat a wound, or learn a new habit. Don't leave the panhandle over the edge. Calling pain communication helps reframe it. It's not a moral punishment for using your body, nor is it a personal failing when something aches. It's an ancient alarm system evolved to keep us alive. Imagine early humans without pain. You could touch a hot ember, step on glass, or get a feverish infection and never know. The alarm never went off, and gradual damage accumulated until it was too late. Pain, forced withdrawal, healing, and the hard-won lessons that made survival possible. The biology is surprisingly elegant. When tissue is injured, chemical signals flood the area, things like prostaglandins and bradykinin, and they sensitize nociceptors. Those nociceptors convert the chemical language into electrical impulses, action potentials. Afferent neurons shuttle these impulses to the spinal cord. From there, the message can take several paths. Simple reflexes, routing to brain regions that register the sensation, and connections to emotion and memory centers. That's why pain isn't just physical. It's wrapped in fear, memory, and attention. A scrape you barely notice while you're excited can feel enormous when you're alone and anxious. Because pain is a message, context matters. Ever stub your toe at the gym and barely notice because you're pumped and focused? Then later, when you're lying in bed, the pain blossoms? That difference comes from the brain's filtering system. Attention, mood, and past experience amplify or dampen the signal. Pain tells you something, but your brain decides how loudly to listen. Hearing pain as communication also helps us understand two critical real-world problems. What happens when pain is absent? And what happens when the message system goes haywire? First, absence. There are rare genetic conditions, like congenital insensitivity to pain, where people don't feel pain. It sounds like a superpower until you realize the consequences. Kids with this condition often sustain burns, broken bones, and internal injuries that go unnoticed until they're severe because there was no alarm to stop the behavior or call for help. Even more common is neuropathy from diabetes. When nerves are damaged, feet can develop sores that progress to infection because the person never felt the initial pain. These examples are stark reminders that pain, for all its unpleasantness, is fundamental to our survival. Second, the message system can malfunction. Chronic pain is when the alarm keeps ringing long after the immediate danger has passed, or when the system becomes hypersensitive to everyday inputs. I used to ignore a nagging shoulder ache for months. It's nothing, just stiff, until a weekend hike turned it into a limit on everything I did for a year. My body had been sending repeated warnings. By ignoring them, I let a small, fixable problem become entrenched. That's a common pattern. Short-term protective pain becomes long-term suffering when the nervous system changes the rules. The pain system, meant to protect, can sometimes overprotect. Understanding pain as a language changes how you respond. Instead of seeing pain as shameful or purely adversarial, you can treat it as information. Ask, what is the body trying to protect? Is this a new, acute alarm that needs immediate attention? Stop, ice, immobilize, see a professional. Is it a reminder to slow down and let tissue recover? Or is the alarm system itself overactive and in need of retraining through movement, therapy, or other approaches? That mindset also changes behavior in practical ways. If you twist an ankle, you don't tough it out, because the pain's not a punishment for being weak. It's a signal to reduce load, use support, and allow tissues to repair. If a headache shows up during a stressful week, pain is pointing at the need for rest, hydration, or maybe a boundary you haven't set. When we treat pain as a messenger, we start asking useful questions instead of assigning blame. Pain's evolutionary purpose is brutally simple. Survival begins with awareness. From the smallest insect bite to the most intense post-operative agony, pain is a biological truth telling you where to focus attention. It forces rest, drives protective behavior, and shapes learning so that harmful situations are avoided in the future. So next time you feel an ache or a twinge, don't immediately label yourself as weak or unlucky. Pause for a moment and listen. Where is the message coming from? What does it want you to do? Listening doesn't mean accepting suffering as inevitable. It means interpreting the body's language so you can respond wisely. In the next chapter, we'll explore what happens when that language gets distorted and how modern medicine and movement science help translate and retune the system so the alarm rings appropriately again. Chapter 2. The Journey of a Signal. Every pain signal is a story told in milliseconds. A tiny, electrified sentence that begins at the edge of your being and ends up being read, interpreted, and judged by the most complicated organ you own. To make that feel real, let's follow one of those sentences from start to finish. Imagine you're walking barefoot in the kitchen. Your foot meets the corner of a forgotten coffee table. The gasp, the jump, the ouch. All of it is your nervous system, translating one moment of tissue irritation into a full-bodied experience. The first chapter in that story starts with a receptor, a specialized nerve ending called a nociceptor, tucked into your skin, muscle, or joint. These receptors sit quietly most of the time, but the moment tissue is stretched, heated, cut, or chemically irritated, they fire. Some nociceptors are built for speed, the thinly myelinated A delta fibers that send a sharp, immediate message. That's hot. Pull away. Others are slower, the unmyelinated C fibers that carry a dull, lingering ache, the kind that arrives after the initial shock and tells you something needs time to heal. That tiny electrical impulse, a change in voltage across a nerve cell membrane, races up the nerve like a courier. It reaches the spinal cord in a matter of milliseconds. Here, at a structure called the dorsal horn, the signal doesn't simply pass through unchanged. This is the first place the nervous system decides whether to amplify the message, damp it down, or pass it on as is. Think of it as a railroad junction where signals can be rerouted. Some are allowed to continue upward, some are interrupted, and others are joined by new passengers, inflammatory chemicals, molecules released by damaged tissue that can make the whole signal louder. There's also another layer of control at the spinal level, often called the gate. This is not a literal gate, but a useful metaphor. Inputs from other parts of the body, or signals telling your nervous system to relax, can close that gate a little, reducing the flow of nociceptive traffic heading to the brain. That's why rubbing a bumped elbow feels comforting. The non-painful touch competes for attention and can lower the pain signal's volume before it ever reaches conscious awareness. If the signal makes it past the spinal cord, it's sent up through a network of ascending pathways toward the brain. In only a few dozen milliseconds, it arrives at the thalamus, the brain's relay station. The thalamus is less like a passive postman and more like a multi-room control center. It forwards the incoming message to several destinations, each reading a different part of the same note. One area asks, "Where exactly did this come from?" That's the primary somatosensory cortex. It maps the body and decodes intensity and location. Another area asks, "What does this feel like?" The insula helps translate raw signals into subjective sensations: burning, stinging, aching. Yet another area, the anterior cingulate cortex, engages when pain has a strong emotional component. It's the part of the brain that registers how unpleasant the experience is. And then there are the parts that file the event into your life story. The amygdala, our emotion center, and the hippocampus, our memory center, take a close look and stamp the signal with meaning. Were you already anxious? Did you hear a scream? Is this similar to a past injury that took months to heal? Those associations can be attached in a fraction of a second, and suddenly the same nociceptive input can feel very different depending on context. That's why a paper cut in the middle of a tense deadline might feel like the end of the world, while the same cut at a picnic barely registers. The brain weaves together intensity, location, emotion, and memory into what you finally experience as pain. One of the most surprising things about this process is how fast the brain's emotional systems influence the raw sensory data. Anxiety and fear don't wait politely at the end of the line. They bias the signal en route. When your amygdala is on high alert, because you've been stressed all week, because you're worried about a diagnosis, because you're sleep deprived, it sends back facilitatory signals that can amplify spinal processing. In practical terms, pain feels sharper when you're anxious. Conversely, when you're calm, when your body is in a relaxed state, descending systems from the brainstem release natural pain-relieving chemicals, endorphins, serotonin, noradrenaline, that act like dampers on the electrical signal. Deep breathing, focused attention elsewhere, or being in the presence of someone who comforts you can tip the balance toward inhibition, making the same stimulus feel softer. Put another way, the physical event, tissue damage, pressure, heat, is only the first sentence. The rest of the story, and how loud or quiet that sentence reads to you, depends on a conversation between sensory pathways and the brain's emotional and cognitive centers. Expectation plays a role too. If you believe something will hurt, it often does. If you believe a treatment will help, it often does. This is the basis of placebo and nocebo effects. Powerful reminders that the story of pain is co-authored by the body and the mind. That narrative quality of pain is especially clear when you compare acute, obvious injuries to chronic pain. With acute pain, the path is short and the message obvious. Pull your hand off the stove. But with chronic pain, the story keeps getting retold. The nervous system can become sensitized. Synapses become more excitable. Circuits that represent pain become more easily triggered, and memories of pain make future pain more likely. It's not just that your tissues hurt more. It's that your nervous system learns to speak pain more fluently. This is why two people can have similar scans or injuries and very different experiences. One's nervous system decided to turn up the volume, the others did not. There are human moments that capture this perfectly. I remember once pinching my finger in a jam jar. At first it was a sharp, burning jolt, the classic A-delta response. A minute later, as the adrenaline settled, the ache lingered and felt oddly tolerable because I was laughing with friends, distracted and calmed. Contrast that with the time I had a persistent back pain flare during a week of deadlines and bad sleep. Everything felt worse, smaller stresses magnified, and the pain that would usually be a background hum took center stage. Same body, very different stories. Knowing how quickly and flexibly these stories form matters. It means pain isn't a fixed fact. It's a dynamic narrative that responds to attention, context, memory, and mood. It helps explain why hands-on treatments, social support, cognitive reframing, and even simple breathing exercises can change the experience of pain, because they aren't attacking tissue alone. They're interacting with the narrative layers that shape the final reading of that millisecond-long message. So the next time you feel pain, try to think of it as a sentence in a fast-moving story. Who is reading it? What other notes are attached? And whether the tone could be shifted. That perspective doesn't make the sensation less real, but it does open up options. Pain is immediate, yes, but it's also malleable. And understanding the journey from receptor to thalamus, from raw signal to felt experience, is the first step in learning how to influence that journey. Chapter 3: The Birth of a Painkiller. Think about the last time you reached for something to dull a headache, calm a fever, or sleep off a night of pain. That little pill or spoonful of syrup didn't arrive by accident. It's the end point of a long human conversation with nature. Chapter 3 tells that story, how instinct and curiosity turned bitter bark and sticky sap into the medicines most of us trust today. We begin where everyone begins, outside. Long before microscopes and lab coats, people learned by watching what happened when animals grazed, when neighbors chewed roots, when a healer brewed a tea. If a plant eased a fever or stopped a toothache, That knowledge traveled, passed mouth to mouth, generation to generation. Some discoveries were lucky. Some were terrifying, but all of them were experiments in survival. My grandmother used to tie a strip of willow bark to a string and keep it in her kitchen drawer, just in case. She'd say, "When your head won't stop pounding, steep that and rest." It wasn't science to her. It was an old habit that worked. That habit contains the kernel of everything that came after. Humans learning from nature's chemistry. The willow tree is where the story becomes traceable. People have chewed willow bark for millennia to reduce pain and fever. Hippocrates noted its benefits more than 2,000 years ago. What he described as a folk remedy would eventually lead to one of the world's most recognizable medicines. Inside willow bark is a compound called salicin. Once ingested, your body converts salicin into salicylic acid, a molecule that helps lower inflammation and quiet the chemical alarms your injured tissues send out. Salicylic acid works, but it irritates the stomach. That irritation pushed chemists to ask, can we keep the benefit and lose the bite? Enter chemistry. The idea that if we could change the molecule slightly, we could keep what heals and remove what harms. In the late 19th century, chemists found a way to acetylate salicylic acid, turning it into acetyl salicylic acid, aspirin. It was gentler on the stomach and still knocked down pain and fever. Aspirin is a great example of how human observation and chemical refinement combine. Learn from a plant, identify the active ingredient, tweak the structure, and scale the production. While willow bark taught us about anti-inflammatory pain relief, another plant taught us about power and peril: the opium poppy. Opium has been used for thousands of years as a pain reliever and sedative. People used opium in many forms, from poultices to tinctures. Then, in the early 19th century, a German pharmacist named Friedrich Serturner isolated the primary active ingredient from opium and named it morphine, after Morpheus, the Greek god of dreams. For the first time, we had a defined molecule whose effects could be studied, measured, and, crucially, manufactured with consistency. Think about what that meant. Instead of a variable, sticky resin, doctors now had a reproducible compound that could be dosed accurately. But with potency came cost. Morphine eased pain like nothing before it, but it also bound people to dependence. That's a pattern we still see. Every leap forward brings new questions about safety, access, and unintended consequences. By the 20th century, medicine had more than one molecule to work with, and scientists were no longer content with, "This seems to work." They wanted to know how. Pain stopped being a vague sensation and became a chain of chemical messages. Injured cells release mediators. Nerves carry electric and chemical signals. The spinal cord relays them to the brain, and the brain interprets them as pain. Aspirin and other non-steroidal anti-inflammatory drugs, NSAIDs, work on one key part of that chain. They stop the production of prostaglandins, the molecules that tell your nerve endings to get noisy. They do this by blocking enzymes called cyclooxygenases, or COX enzymes. By lowering prostaglandins, NSAIDs reduce inflammation and quiet the signal before it becomes a loud, throbbing complaint. Morphine and other opioids work differently. They don't stop the message from being made. They act at the receivers. Morphine binds to opioid receptors in the brain and spinal cord and turns down the volume on pain perception and the emotional response that makes pain feel so awful. It's like moving the pain's radio knob from 11 to 3. But because those same receptors affect reward and breath control, opioids have serious side effects. The 1900s brought huge leaps. Chemists figured out how to synthesize molecules the body doesn't make naturally. Doctors began to systematize dosing in clinical trials, and companies scaled production so more people could access relief. Acetaminophen, known as paracetamol, emerged as a pain reliever with different strengths and risks, gentler on the stomach than aspirin, but dangerous in overdose to the liver. Ibuprofen came along in the mid-20th century, offering an effective over-the-counter option. Later, scientists discovered COX-2, a variant of the enzyme more active at sites of inflammation, and designed COX-2 inhibitors to reduce stomach side effects. Though that route showed us there are always trade-offs, including unexpected cardiovascular risks. Every improvement tried to isolate benefit from harm, reduce stomach ulcers, reduce addiction, reduce organ stress. Each decision was guided by better tools, better chemistry to modify molecules, better biology to map receptors and enzymes, and better clinical science to see the population-level effects. When you hold a pill, an unassuming disc or capsule, you're holding condensed history. That little object is the result of observation at a riverbank, a shaman's experiment, an 1800s chemist's notebook, a 20th century clinical trial, and a 21st century regulatory debate. It is a compromise between nature's messy complexity and our appetite for consistent, predictable effects. You and I probably take different analgesics for different reasons. Maybe you reach for aspirin as a habit, or ibuprofen when a headache strikes, or acetaminophen for a child with a fever. Maybe someone you love has been prescribed opioids after surgery. Each of those choices reflects a personal history and a scientific history intertwined. Understanding where these drugs came from helps us use them better. It helps us respect their power and weigh their risks. It also gives us a clearer view of why the next innovations, whether they're safer opioids, precision analgesics, or non-drug pain therapies, won't come from a single breakthrough, but from many small steps: observation, chemical insight, biological understanding, and ethical reflection. So the birth of the modern painkiller is not a single moment, but a long conversation between people and nature, stitched together by chemistry. That conversation taught us how to silence pain's signal without destroying the messenger, and it set the stage for everything that comes after. How we regulate these medicines, who gets access to them, and what mistakes we must avoid. Chapter 4. How painkillers enter the body. You pop a pill, and for a moment it feels almost private, a small, ordinary action. But that tablet is about to begin a surprisingly dramatic journey. Picture this. You tilt your head back, swallow, and the tablet slips past your throat. It doesn't immediately go to your pain like a heat-seeking missile. Instead, it starts a quiet, methodical trip through your digestive tract, and the real work begins. First stop, the stomach. If you've ever felt a pill dissolve on your tongue, the stomach is doing something similar on a larger scale. Gastric acid and digestive enzymes start to break down the tablet coating and the binders that hold it together. That process releases countless tiny drug molecules. Depending on the kind of pill you took, this could happen quickly, for an immediate release tablet, or very slowly if it's an enteric-coated or extended release formulation designed to dissolve further down the digestive tract. From the stomach, most of these molecules move into the small intestine, which is where absorption really ramps up. The small intestine has a huge surface area, folded and lined with villi, and it's built to transfer nutrients and, unintentionally, many drugs into your bloodstream. The lining is thin and richly supplied with tiny blood vessels. The moment those drug molecules reach this zone, many slip across the intestinal wall and enter the capillaries. That crossing is mostly passive. Small, fat-soluble molecules drift through cell membranes more easily, while others use transporters or channels. The exact chemistry of the drug, its size, whether it likes water or fat, whether it's ionized, determines how fast it makes this leap. Once inside those capillaries, the molecules flood into your bloodstream. Think of your circulatory system as a vast, fast-moving highway system. In minutes, sometimes as quickly as 15 to 30 minutes for common oral painkillers, drug molecules are whizzing through arteries and veins, reaching every organ, every tissue, every cell that blood reaches. Plasma carries them to the liver first through the portal vein, where metabolism can take a bite out of the dose in a process called the first pass. That's why two different people taking the same pill can experience relief at different speeds or strengths. Your liver, your stomach acidity, the food in your gut, even your genetics, all shape how much of the active drug actually makes it into general circulation. A detail that surprises a lot of people: the pill doesn't seek out the sore spot. It doesn't scan your body for the loudest signal and head straight there. Instead, the molecules diffuse everywhere. They're evenly distributed by the blood. They go to your fingers and your brain and the bruise on your shin alike. But whether they can get into a particular tissue and do anything once they're there depends on a few things. Can the drug cross the tiny barriers that protect certain tissues? Is it bound to proteins in the blood? And does the target tissue express the right biochemical doorways, receptors, enzymes, or ion channels for that drug to act on? Picture the drug molecules as a swarm of tiny keys carried in a current. Each key will unlock certain doors, but only if those doors exist in the buildings they pass. Some doors are everywhere, like enzymes that make prostaglandins, the inflammatory chemicals that amplify pain and swelling. And that's why non-steroidal anti-inflammatory drugs, NSAIDs, like ibuprofen or aspirin, can relieve a sore knee or a pounding headache. NSAIDs inhibit cyclooxygenase, COX, enzymes, which are involved in prostaglandin production. With fewer prostaglandins, inflammatory signals quiet down. Other drugs are more selective. Opioids, for example, are keys that fit mu-opioid receptors concentrated in the spinal cord and brain, places that modulate how strongly you perceive pain. For those drugs, part of their journey includes crossing the blood-brain barrier, a tightly regulated gate that only lets certain molecules into the central nervous system. You might ask, if the drugs are everywhere, why does relief feel so targeted? The short answer is, the body's loudest signals come from the places that are most damaged or inflamed. A sprained ankle bleeds and swells. Nerves there fire off painful alarms. That region gets more blood flow, more immune activity, more of the biochemical machinery that painkillers can interrupt. So, when a drug neutralizes some of those signals, the part that was the loudest drops first, and it feels like the painkiller found the hurt. In reality, the drug was in the same bloodstream as everything else. The injured tissue simply presented more opportunities for the drug to do its job. There are also physical reasons injured areas are more accessible to some drugs. Inflammation makes local blood vessels leaky and increases blood flow. That means more drug can leave the capillaries and enter the swollen tissue. For drugs that work peripherally, outside the brain, that leaking is a boon. For drugs that need to act centrally, the blood-brain barrier's selective nature can be a limiting factor. Protein binding in the blood is another piece of the puzzle. Many drugs attach temporarily to carrier proteins like albumin. When bound, they're essentially inert. They can't cross membranes or latch onto receptors. A smaller fraction floats free, and it's that free fraction that can enter tissues and do the work. Conditions that change protein levels, chronic illness, interactions with other medicines, can alter how much free drug you have, shifting both effectiveness and side effects. Timing matters too. You've probably noticed that sometimes a pill seems to kick in faster than usual, and other times it takes longer. That variability comes from digestion speed, pill formulation, whether you took it with a full meal, and individual differences in absorption and metabolism. Some pills are made to dissolve slowly to keep the drug in your system longer. Think of taking a 12-hour pain patch versus a quick tablet for sudden pain. Others dissolve quickly so you get rapid relief. And remember the liver's role. Certain medications are heavily metabolized on their first pass through the liver, so only a fraction may ever reach systemic circulation. That's why dosing and timing are carefully worked out by scientists. There's also a trade-off built into this system. Because painkillers travel everywhere, they can act where you want them to, but they can also act where you don't. NSAIDs reduce prostaglandins all over your body, which can irritate the stomach lining or affect kidney function in sensitive people. Paracetamol, acetaminophen, relieves pain and fever largely through central mechanisms, but taken in high doses, it strains the liver. Opioids act powerfully in the brain and spinal cord, but can also depress breathing and cause sedation. The universal circulation that brings relief is the same highway that carries risk. On a personal note, I remember after a weekend soccer game staying up later than I should have, then waking with a throbbing temple. I swallowed an ibuprofen, expecting the usual half-hour turnaround. I could almost feel the drug bloom in my bloodstream, that odd, hard-to-describe transition from "this hurts" to "okay, that's manageable." It wasn't that the medicine had tracked my temple like a detective. The ibuprofen had spread through my body in the blood, and because my headache was the loudest signal at that moment, the reduction in pain there felt dramatic and specific. That's the practical takeaway. Pain medications don't pursue pain. They ride your circulatory system, sampling tissues, slipping through cellular doorways if chemistry allows, and doing their work where the conditions are right. The sensation of targeted relief comes from the intersection of drug chemistry, local biology at the injured site, and the way your nervous system prioritizes signals. Coming up next, we'll zoom in on those biochemical doorways, the receptors and enzymes that actually accept or reject these tiny chemical keys, and see how some drugs close the volume on pain signals while others change how your brain interprets them. Chapter 5. The Chemistry of Pain, Prostaglandins, and Enzymes. Think of inflammation as a controlled burn. The body lights when something's gone wrong. A cut, a sprain, even a flashing pain behind your eye. It's not spiteful. It's purposeful. The body calls in extra blood, immune cells, and chemicals to clear damage and start repair. But that cleanup crew comes with collateral damage: redness, swelling, heat, and that hollow, nagging ache that makes you wince every time you move. At the center of that controlled burn are prostaglandins, tiny chemical sparks that tell the body to turn up the heat. They're produced at the site of injury and do two important things. They dilate blood vessels, which bring swelling and warmth, and they sensitize nerve endings, so even a light touch feels like a shout. When prostaglandins pile up, the pain signal gets amplified, and your joint or muscle becomes exquisitely sensitive. That sensitivity is useful. It keeps you from re-injuring something while it heals. But too much of it turns healing into misery. Let's break down, in plain terms, how those sparks get made. Picture a construction site. The cell membrane is a brick wall, and when it's damaged, workers release a building block called arachidonic acid. A pair of enzymes, cyclooxygenase 1 and cyclooxygenase 2, usually shortened to COX-1 and COX-2, step in like foremen and convert arachidonic acid into an intermediate, which then becomes a family of prostaglandins and related molecules. Some of those prostaglandins cause pain and inflammation. Others are more like caretakers, protecting the stomach lining or helping platelets stick together to form clots. This is where the common painkillers come in. NSAIDs, non-steroidal anti-inflammatory drugs, the family that includes aspirin, ibuprofen, Advil, Motrin, and naproxen, Aleve, work by getting between those foremen and their work. They block COX enzymes, so fewer prostaglandins are produced. With fewer sparks, the controlled burn cools down, swelling eases, the area becomes less sensitive, and the pain signal to your brain quiets. That moment when a pill seems to find the pain and make it vanish is a little misleading. The drug isn't a heat-seeking missile. It's more like a firefighter who lowers the oxygen so the flames fizzle. The pain you feel doesn't move. The chemical signals that were amplifying it are reduced. You perceive relief because the environment around the nerves has shifted from "why does every bump hurt" to "this is manageable." That's why the act of taking a tablet can feel so dramatic. The contrast between throbbing and calm is immediate and gratifying. A couple of practical things help this click with everyday experience. Remember a bad headache that would not quit until you took something? Headaches, especially inflammatory ones like tension or some migraines, are driven in part by prostaglandin activity around blood vessels and nerves. Or think about menstrual cramps. The uterus contracts more strongly when prostaglandins are high, and NSAIDs reduce both the prostaglandins and the cramps. Sprains and strains feel swollen and tender because prostaglandins signal for fluid and immune cells to arrive. When those signals drop, the swelling and sensitivity fall too. But biology rarely comes without trade-offs. COX-1 has useful housekeeping duties, particularly in protecting the stomach lining and supporting platelet function. When NSAIDs block COX-1 as well as COX-2, that stomach protection can be reduced, which is why some people get gastritis, ulcers, or bleeding after prolonged NSAID use. That's also why aspirin, which irreversibly disables COX enzymes in platelets, can thin the blood and is sometimes used deliberately to lower the risk of clots, but at the cost of increased bleeding risk. Because of these downsides, drug developers designed COX-2 selective inhibitors. One well-known example is celecoxib. These tend to spare the stomach while still dousing the inflammatory sparks. They work well for many people, but they've taught us another lesson. Interfering with prostaglandins can upset the balance in unexpected ways. Some COX-2 inhibitors were linked to higher rates of cardiovascular events in certain groups, reminding us that prostaglandins also have roles in blood vessel health and clotting. When you change one piece of a complex system, other pieces can wobble. Timing and dosage matter too. NSAIDs don't extinguish the tissue's underlying problem, a torn ligament, bacterial infection, or autoimmune attack, so relief can be temporary. If the underlying cause persists, the chemical signals will rebuild, and the pain can return once the drug wears off. That's why short-term use for flare-ups or carefully monitored longer-term use under a doctor's guidance is often the safest path. There's also an important distinction to mention. Not every pain reliever douses prostaglandins. Acetaminophen, paracetamol, reduces pain and fever, but doesn't have the same anti-inflammatory punch. Its exact mechanism is more complex and still debated, but it appears to act differently, possibly in the brain, rather than at the site of inflammation. So if you're dealing with swelling and redness, an NSAID tends to be more effective than acetaminophen. If you're looking just to reduce a fever or take the edge off a headache without anti-inflammatory effect, acetaminophen can be handy. Here's something people don't always realize until they experience it. While NSAIDs reduce pain by lowering prostaglandins, those same molecules are also part of the healing orchestra. In some situations, dampening inflammation too much or for too long can slow the repair process. An athlete who repeatedly suppresses the inflammatory response in a recurring injury might find the pain tolerable, but the tissue never fully regains strength. That's why athletes and clinicians sometimes balance rest, physical therapy, and selective use of meds instead of relying solely on pills. When you next pop a pill and feel the ache ebb, take a beat to appreciate the tiny chemistry that made that relief possible. The quieting of prostaglandins, the temporary cooling of the body's controlled burn. The drug didn't find the pain like a spotlit detective. It simply turned down the dial on the body's internal alarm. Understanding that makes you a smarter consumer of pain relief. Someone who can weigh benefits, risks, and alternatives, and use these tools to support real healing rather than just masking symptoms. Now that we've cooled the chemical sparks, we can look at how the nervous system translates that quieter signal into perception, why the brain sometimes magnifies pain and, in other moments, lets it pass. Chapter 6. Inside the Brain. Rewriting the signal. Now let's move from the sore elbow, the swollen ankle, the red welts on your skin, into the control room, the brain. We've already looked at how many painkillers act where the problem starts, calming inflammation, reducing swelling, stopping prostaglandins in their tracks. But some of the most familiar pills in your medicine cabinet don't play there at all. Acetaminophen, Tylenol, is the quiet one. It doesn't douse the fire of inflammation the way ibuprofen or aspirin do. Instead, it turns down the volume inside your head. Picture pain as a radio station broadcasting at full blast. Peripheral pain, the kind you get from tissue damage, is the signal being sent. Anti-inflammatories are like going outside and stopping the transmitter at the source. Acetaminophen walks into the listening room and fiddles with the dial. The music's the same, but the sound coming through your speakers is softer, less urgent. That's not numbness. It's reinterpretation. Why would the brain need reinterpretation? Because pain isn't just a simple ouch notification. It's a complex conversation between sensation, memory, expectation, mood, and context. Two people with the exact same injury can report wildly different pain. One winces and can't sleep. The other says it's annoying but manageable. That difference lives in the brain, how it receives and makes sense of the signal, and acetaminophen works there. So how does it do that? Scientists are still working through the details, and the picture is more of an evolving sketch than a finished painting. But several clues point to mechanisms that change how pain is interpreted rather than how it's generated. One idea is the serotonin angle. Serotonin is famous as a mood chemical, but it plays many roles, including in pain modulation. The brain has descending pathways, highways that run from higher brain centers down to the spinal cord, that can either amplify or dampen incoming pain signals. Serotonin is one of the messengers on those highways. There's evidence acetaminophen can influence serotonin levels or how serotonin signals are handled. If those descending pathways are nudged toward inhibition, the brain learns to quiet the incoming pain. You still have the signal. The brain decides not to ratchet it up to crisis level. Another line of research focuses on enzymes and molecules that control how the brain evaluates both sensory input and emotional context. Some studies suggest acetaminophen may block key enzymes tied to the production of prostaglandins inside the brain or interfere with molecules involved in emotional processing circuits. That's a big deal because pain isn't only about the nerves firing, it's about the meaning we assign to that firing. Is that twinge a minor setback or a catastrophe? A small shift in the brain's chemistry can tilt that judgment. There's also growing interest in the endocannabinoid system and other lesser-known receptors. A breakdown product of acetaminophen can bind to receptors that influence both pain sensation and mood. That can subtly change the tone of how pain is experienced, again, not eliminating the signal, but changing its emotional volume. Let me give you a personal comparison to make this feel more concrete. Imagine the last time you had a headache so bad it made you grumpy and foggy. You take a dose of acetaminophen and, 15 to 30 minutes later, you're still aware of a dull pressure, but you can focus on your work. You don't spiral into irritability, and you can enjoy your evening. The headache didn't vanish into nothing. You didn't lose all feeling, but your relationship to the pain shifted. That's the brain rewriting the signal. A striking example of this phenomenon comes from research that looked beyond physical pain into emotional hurt. In some studies, volunteers who took acetaminophen reported blunted emotional reactions to both negative and positive stimuli. People felt less upset by social rejection, and at the same time, less elated by good news. That suggests acetaminophen may dampen how strongly the brain responds to emotional inputs, including the emotional component of pain. It's a reminder that pain sits at the intersection of body and mind. Change one chemical balance and the whole experience can shift. It's worth pausing to emphasize the subtlety here. We're not talking about anesthesia. Acetaminophen doesn't create numbness. You're not asleep to the world. Instead, it's like having a sympathetic friend who reassures you when you stub your toe. It'll pass. It's not that bad. That reassurance, emergency or not, can change how your nervous system prioritizes the signal. When the brain interprets a message as manageable, downstream processes that amplify pain are less likely to kick in. This central action also has practical implications. Because acetaminophen doesn't tackle inflammation, it won't reduce swelling or limit tissue damage. If your knee is inflamed from an overuse injury, anti-inflammatories or a steroid might be more effective at treating the underlying process. But if the goal is to get through a workday with a splitting headache or to stop a fever from making you miserable, acetaminophen's ability to rebalance how the brain interprets discomfort is often exactly what people need. There's an important flip side to all this. Because acetaminophen operates on the brain's interpretation systems, it can mask not only ordinary pain, but also the emotional signals that tell us something's wrong. If you rely solely on it to get through chronic pain, you might downplay important warning signs. That's why communication with your healthcare provider matters. To pair symptom relief with strategies that address the root cause when necessary. Another practical consequence is how acetaminophen interacts with thinking and decision-making. If it dampens emotional reactivity, it can also blunt risk perception in subtle ways. Studies have shown that people on acetaminophen may make different moral judgments or take slightly different risks than when they're not. That's not a reason to avoid it. Usually the effect is small and short-lived, but it's a reminder. Drugs that change our internal maps change behavior too. Finally, there's the broader lesson about pain management. Because acetaminophen acts centrally, it's often used in combination with other drugs that work peripherally. For example, doctors might recommend alternating acetaminophen with an NSAID for severe toothache. The NSAID reduces the inflammation and swelling at the root, while acetaminophen makes the overall experience more tolerable by calming the brain's response. That combination can be more effective than either alone, but it must be done safely, adhering to dosing guidelines. Before moving on, a quick, practical takeaway. Acetaminophen can be a powerful tool when you need relief from the subjective experience of pain, headaches, mild injuries, fever-induced misery, because it changes how the brain receives and prioritizes pain signals. It's not a fix for inflammation-driven conditions, and because it works centrally, it can alter emotional responses and cognition modestly. Always follow dosing recommendations and talk to your clinician if you're using it frequently for chronic pain. Next, we'll look at how this brain-centered approach compares with newer pain therapies that target the nervous system more precisely. Things that don't just nudge the dial, but reprogram specific circuits. We'll explore what that means for long-term pain control and what's on the horizon for people who live with pain day in, day out. Chapter 7. The Opioid Connection. You've felt it before, a sharp ache after an injury, or that dull, constant background pain that makes everything a little harder. Now imagine the relief of something that doesn't just numb the edge, but seems to soften the whole world. Sounds brighter, breathing easier. The anxiety that rides pain like a shadow just lifts. That's the promise of opioids. Opioids, morphine, codeine, oxycodone, and their relatives, do something our own bodies try to do naturally. We make chemicals called endorphins that act like internal painkillers. They bind to opioid receptors in the brain and spinal cord and tell the nervous system to turn the volume down. Prescription opioids mimic those endorphins. They fit into the same receptor sites, and when they do, the result can feel like relief and calm rolled into one. Picture a lock and key. Endorphins are the small keys your brain makes when it needs to dim pain after a sprint or a scare. opioid medications are much stronger master keys. They open the same locks, but with more force, more sustained closure. That extra strength is what makes them life-saving in emergency rooms and after major surgery. For someone crumpled in an ambulance or recovering from a broken pelvis, that push of relief is not optional. It's what lets them breathe, sleep, and start to heal. Because of that power, opioids can feel like mercy. I've heard from people who describe their first doses after surgery as a kind of profound gratitude. I could finally sleep, one friend told me after he'd been awake with pain for 3 days. That restorative calm is real, and when used carefully and for a short time, opioids can be exactly what a person needs. But here's where things turn complicated. The same chemistry that brings peace can also rewire the brain. When opioids flood those receptor sites repeatedly, the brain adapts. Receptors can become less sensitive. Your body says, in effect, this much opioid no longer feels like enough, and you need a higher dose to get the same relief. That's tolerance. It's not moral failing. It's biology adjusting to an external signal. Simultaneously, the brain's reward circuitry, the network that lights up when we experience pleasure, learns to associate the drug with relief, calm, even safety. That association can hijack motivation. Ordinary joys dim in comparison. Activities that used to feel rewarding may feel flat unless the drug is present. That's addiction, a shift from using for relief to using to feel normal, to avoid withdrawal, to chase a feeling your brain now expects from the drug. Pain fades, but dependence begins, chemistry's sharpest paradox. Dependence itself is a physical process. When the drug is removed, the body reacts. Flu-like symptoms, anxiety, restless legs, insomnia, sweating. Addiction adds compulsive behaviors on top of that, risky patterns, and an overriding drive to seek and use despite harm. It helps to separate 3 ideas that often get tangled: relief, tolerance, and addiction. Relief is the intended effect. The patient who sleeps and can walk after a hip replacement. Tolerance is the biological adaptation that can make the same dose less effective over time. Addiction is when use crosses into compulsive, harmful patterns. Not everyone who takes opioids for pain becomes addicted, but the risk is real and rises with longer use, higher doses, and certain social or genetic vulnerabilities. Think about a story you might recognize. Someone has their wisdom teeth removed, gets a short prescription for a few days, takes it as directed, and recovers. No problem. Now imagine a different scenario. A person with chronic back pain gets a steady supply for months, and after a time, finds they need more to get the same relief. They might start taking a pill earlier than prescribed, or spending more time thinking about when they can get the next dose. That's the slippery slope, not because opioids are evil, but because they're biologically persuasive. There are other human elements too. Emotional pain and isolation make the calming effects of opioids more seductive. People dealing with anxiety, loss, or depression can find the sense of ease opioids provide particularly attractive. A reminder that addiction is rarely just about physical dependence. It's about what the drug does for your inner life, as well as your body. What can help? First, honest conversations with clinicians. If you're prescribed an opioid, ask how long you'll need it, what alternative pain strategies exist, and what signs to watch for that suggest tolerance or problematic use. Use the lowest effective dose for the shortest possible time. Combine medication with non-drug approaches, physical therapy, guided movement, heat or cold, mindfulness, and when appropriate, non-opioid medications. Store pills securely and dispose of unused medication properly. Many addictions begin with leftover prescriptions in a medicine cabinet. If you notice you're taking more than prescribed, feel anxious about running out, or that the medication is the only thing that makes daily life bearable, reach out. There's no shame in asking for help. Treatments exist that can reverse overdose, like naloxone, and a range of programs and medications can support people through dependence and addiction with dignity. The Opioid Connection is one of the clearest examples of how medicine can heal and harm using the exact same mechanism. It's a reminder that our brains are both wonderfully resilient and vulnerable. By understanding the biology, how opioids mimic endorphins, bind receptors, and can rewire reward systems, we get clearer tools to use them safely and compassionately. In the next chapter, we'll look at alternatives and strategies that help manage pain without escalating risk, and how communities can support people caught between relief and dependence. Chapter 8. The Placebo Effect. When belief heals. Think about a time you took something that wasn't supposed to do anything. Maybe a mint labeled as sore throat lozenge from a well-meaning friend, or a vitamin pill someone swore would help your sleep, and suddenly you felt better. That small, almost silly moment is the placebo effect in action. Belief turning into biological change. Here's the simple version. Sometimes a sugar pill works as well as medicine. But the messy, fascinating truth is why. When you expect relief, your brain doesn't just sit there. It flips switches. Expectation can trigger the release of endorphins, your body's natural opioids, which blunt pain. It can increase dopamine, the neurotransmitter that signals reward and anticipation, making you feel brighter and more motivated. And it can lower cortisol, the stress hormone that makes everything feel worse. In other words, the brain becomes its own pharmacy, dispensing comfort because you expect comfort to arrive. I'll give you a quick example from my life. A few years ago, I had a weekend migraine that ruined 2 days of plans. A friend handed me a tiny white pill from a travel kit and said, with total confidence, "This will take the edge off." I popped it thinking it was likely just a generic painkiller. It wasn't. I later learned it was a vitamin. But within an hour the ache had dulled and the edges of the headache softened. Was it a fluke? Maybe. But that moment made me curious about how much of healing is chemical and how much is narrative. Science backs up that curiosity. In pain studies, people who are told they're getting a painkiller but are given a placebo often report much less pain. Neuroimaging shows activation in the same brain regions that light up when real analgesics are used. In some experiments, giving naloxone, a drug that blocks opioid receptors, erases placebo analgesia. That tells us the placebo effect is not imaginary theater. It recruits the body's own opioid system. In Parkinson's disease, patients given a placebo can show measurable increases in dopamine and temporary improvements in movement. In trials for depression, irritable bowel syndrome, and even post-surgical recovery, placebos can produce surprisingly large effects. Why does this happen? Expectation is a powerful signal. Your brain constantly predicts outcomes and updates those predictions. If the prediction is, "This will help," your brain mobilizes systems that make that prediction come true, reducing pain sensitivity, dampening anxiety, warming you up to social connection, improving mood. There's also conditioning. If you've taken a pill before and gotten better, your body learns to associate the pill-taking ritual with relief. Later, even an inert pill can trigger that conditioned response. This is important because it reframes what we mean by real medicine. Painkillers often work better because we believe they will. The drug's pharmacology matters, but so does the context in which it's given, the doctor's tone, the ritual of taking a tablet, the label on the package. Faith, in this case, is literally part of the formula. That raises ethical questions. Can doctors use placebos without lying? Traditionally, that's been a problem. Deception undermines trust. But newer research offers a hopeful option: open-label placebos. In several trials, patients were told, "This is a placebo pill," but studies show placebos can trigger real mind-body healing. Many still improved. How? Likely through transparent framing. The patient learns that expectation and ritual can help, and by consenting, joins the process. It's also important to be clear about limits. Placebos don't cure infections or replace necessary surgeries. They are strongest in conditions where perception, pain, mood, and stress play big roles. And because responses vary widely between people and situations, we shouldn't expect miracles every time. One last personal note: realizing how much my own mind influenced my symptoms didn't make me cynical. It made me more intentional. I started paying attention to how I framed my expectations, telling myself, "This will help," in a calm, believable way, and creating small rituals around rest and recovery. The result wasn't a magic trick, but a subtle, steady improvement in how quickly I bounced back. Understanding the placebo effect doesn't cheapen medicine, it enriches it. It reminds us that healing is both chemical and conversational, drugs and beliefs working together. Up next, we'll look at how the doctor-patient relationship acts as a therapeutic tool in its own right, and why empathy can sometimes be as powerful as a prescription. Chapter 9: When Painkillers Fail. There comes a moment for a lot of us when the bottle on the bedside table starts to feel like a small, impotent prop in a play. You pop a pill and nothing shifts. The ache remains, or it comes back louder or different. That's not because you're weak or because the medicine didn't work in some moral sense. It's because not all pain is a simple signal you can mute with a chemical button. Think of chronic pain like a record player with a scratched groove. The nervous system learns a pattern and keeps replaying it. That's neuroplasticity doing what it does best: learning. Unfortunately, it can learn the wrong thing. Nerves that once fired only when tissue was damaged start firing more easily. Brain circuits that once paid attention to a single, valid alarm tone begin treating background noise as urgent. This is called central sensitization in the clinic, but you can picture it as a smoke detector that's become overzealous, going off at burnt toast in sunlight. Emotional pain is not a different species. The chips under the hood overlap. When someone breaks your heart, the same regions that process a physical throb, parts of the anterior cingulate cortex and the insula, light up. People who've had their hearts broken report real physical chest pain. People who've had severe burns report emotional numbing. The brain doesn't neatly divide ouch into neat compartments. It repurposes the same wiring for different kinds of hurt. That's why a bottle of pills often misses the mark. Opioids, NSAIDs, muscle relaxants, they target specific pathways. They can be life-changing and essential for many, especially after surgery or major injury. But when pain no longer comes from ongoing tissue damage, but from a nervous system that's learned to be alarmed, drugs alone are often not enough. They can blunt signals, but they rarely teach the nervous system to stop sounding false alarms. So what actually helps? The answer is messy and personal, which is frustrating but also hopeful. Messy means there are many doors to try. The consistent theme across effective approaches is that they retrain the brain and body together. They're less about erasing the pain signal and more about changing how the brain interprets and responds to it. Cognitive behavioral therapy and newer forms like acceptance and commitment therapy are among the best studied. CBT helps you spot thought loops that amplify pain, the "this will never get better," or the "I shouldn't feel this," and replace them with realistic, grounding alternatives. ACT doesn't fight the pain so much as change your relationship with it. You learn to accept unpleasant sensations without letting them define your life. Another user-friendly tool is the pain diary. It sounds basic, but writing down when pain spikes, what you were doing, who you were with, and what your thoughts were trains you to see patterns. Often, emotions and triggers show up clearly. A tense conversation, a rushed morning, a memory. Noticing these connections is the first step to changing them. Meditation gets a lot of buzz, but its value here is concrete. A simple body scan, 5 to 20 minutes, teaches the nervous system to notice sensation without immediately labeling it catastrophic. Breath-based practices reduce the sympathetic fight or flight tone and increase vagal, calming activity. Even 5 minutes of mindful breathing can lower perceived intensity and make pain easier to live with. Movement is medicine, but not in the push-through-it way social media sometimes suggests. When nerves are sensitized, avoidance becomes a trap. The more you stop moving, the more your brain thinks movement is dangerous. Graded activity programs ask for small, consistent steps. 5 minutes of walking, then 7, then 10. Building tolerance and recalibrating the nervous system's expectations. Yoga, Tai Chi, and gentle strength work do more than improve muscles. They offer proprioceptive feedback and predictable, safe movement patterns that tell your brain, "This is fine." The key is pacing. Set tiny, measurable goals and celebrate them. Progress in chronic pain is rarely a straight line, but it's almost always cumulative. Humans are social mammals. Oxytocin, the bonding hormone, isn't just for childbirth or cuddling. It modulates pain pathways. A genuinely felt conversation, a hand held in a hospital room, a trusted friend's laugh, these things alter neurochemistry. They reduce stress hormones and increase the brain's own pain-relieving chemicals, endorphins, oxytocin, dopamine. This is why group programs and peer support matter. Hearing someone say, "I get that," can change the story your brain is telling itself. It's not trivial. Connection is part of the analgesic toolkit. For some people, the next step after talk therapy and exercise is a deeper somatic approach. Techniques like Feldenkrais, somatic experiencing, or trauma-aware bodywork. These practices focus on resetting held tension patterns and the nonverbal memory of the body. If you carry pain in your shoulders or jaw, unlearning that tension can meaningfully change your experience. Practical micro tools you can try tonight. 5-minute body scan before bed. Notice, don't judge. Watch the urge to fix sensations and let them be. Box breathing. Inhale. 4. Hold 4. Exhale 4. Hold 4. Repeat. Great for flare-ups. Activity chunking. Pick one meaningful thing you stop doing because of pain and do a smaller version of it. 10 minutes instead of an hour. Safe movement mapping. With a physio or on your own, find 3 movements that feel neutral or good and do them daily. Connection appointment. Schedule one call or coffee with someone who makes you feel safe. I'm not suggesting we throw out medication. There are moments when drugs are necessary and life-saving. The point is to see them as one tool among many. If you find yourself relying on increasing doses without lasting relief, it's time to bring in a broader plan. A therapist versed in pain, a physical therapist who understands graded exposure, a support group, and a doctor willing to coordinate care rather than just refill bottles. A personal note: when I had a period of persistent back pain, the first relief came from a physio who taught me to move without fear, and a therapist who helped me stop catastrophizing every twinge. The pills took the edge off enough to start doing those things, but they weren't the solution. What actually shifted my life was relearning my body was safe enough to move in small increments and making room to grieve the loss of the old me without letting that grief become a reason to stop trying. This chapter isn't about saying pain is in your head. It's about understanding that the head and the body are in constant conversation. If pills only talk to your body's chemistry, we need other voices. Therapy, movement, meditation, and human connection to talk to the nervous system in ways drugs can't. If you're stuck, you don't have to design the plan alone. Pain clinics, multidisciplinary teams, and informed practitioners exist to help stitch these threads together. The work is often slow and sometimes frustrating, but it's also where sustainable relief lives, in retraining the brain, reclaiming the body, and finding comfort that goes beyond a pill. Chapter 10. The Future of Pain Relief. Picture this. You're sitting in a clinic, exhausted from another round of medications that barely touch the pain. The doctor leans in and says, "We have something new, an implant that can intercept your pain signals before they reach your brain." For many people living with persistent pain, that sentence sounds like science fiction. But over the next few minutes, I want to take you through what that future actually looks like, not as a distant fantasy, but as a patchwork of real projects, early trials, and ideas that are steadily becoming tools doctors can use. Some are close to being in your doctor's office. Others still live in labs, in mice, or in the minds of engineers. All of them share one goal: to give your body back its balance. Let's start at the molecular level. For a lot of chronic pain, the problem isn't damage you can see on an X-ray. It's receptors and channels in your nerves that have gotten stuck in the on position. Think of it like a radio stuck at full volume. The sound is constant, whether a note is being played or not. Gene therapies aim to turn the dial down. Researchers are using viral vectors, harmless viruses repurposed to carry corrective genetic material, to deliver instructions that silence overactive receptors. One promising target is the family of sodium channels in sensory neurons. Mutations in genes like SCN9A can make these channels hyperexcitable. scientists are developing ways to either temporarily block the messenger RNA that makes those channels, or to permanently edit the gene so it behaves normally. There are also approaches using antisense oligonucleotides and RNA interference that act like a mute button, short-term but powerful. What's compelling about gene therapy is precision. Instead of blanket painkillers that float through your whole body, the idea is to silence only the cells responsible for the pain. For you, that could mean fewer side effects and longer-lasting relief. The catch? These are still early days for many pain-related gene therapies. Safety, delivery methods, and long-term effects are being worked out, but the direction is clear. Target the source rather than mask the symptom. Now imagine if a doctor could give you a tiny courier, a nanobot, that swims to exactly the right nerve cell and releases medication there. That's the promise of nanotechnology in pain management. These aren't sci-fi robots with arms. They're engineered particles, often coated with molecules that recognize specific cell types. They can carry small molecule drugs, gene silencing agents, or anti-inflammatory payloads and release them when they detect the right cellular environment. Why does that matter? Because a lot of effective drugs are limited by systemic side effects. If anti-inflammatories or local anesthetics could be delivered to a single nerve bundle, you wouldn't have to worry about liver strain, drowsiness, or gastrointestinal problems. Plus, targeted delivery could let us use more potent drugs at lower doses. We're seeing early work in animals and in lab-grown human tissue, where targeted nanoparticles reduce pain markers without the typical side effects. Translating that safely to people will take time, but the concept changes the relationship between drug and body, from a shotgun blast to a laser pointer. If gene therapy changes what the nerves are capable of producing, and nanobots decide where drugs act, neural implants work on how signals move. Spinal cord stimulators and peripheral nerve stimulators have been around for years, but the next generation is smarter. Closed-loop systems that read nerve activity and respond in real time. Cortical implants that intercept pain before it becomes conscious, and even tiny devices that use light, optogenetics, to control neurons. A closed-loop implant is like having an auto-braking system for your nervous system. Sensors detect patterns associated with a pain flare, firing rates, timing, or specific frequencies, and a small pulse is sent to disrupt that pattern, stopping the pain signal in its tracks. Because the device only activates when it detects trouble, it can be far more efficient and produce fewer side effects. For some people, these devices already transform life. For others, they don't quite stick the landing yet. The future versions will be smaller, self-adjusting, and more selective, aiming to restore normal signaling instead of simply masking sensations. Not every future treatment needs wires or genes. One surprisingly effective path is something you already own: your brain's attention. Virtual reality isn't just for gaming. It's a powerful tool for redirecting the senses and for retraining the brain's response to pain. Pain is as much about context as it is about sensation. When your attention is fully absorbed in a rich, immersive environment, the brain has fewer resources left to magnify pain signals. VR therapies combine distraction with graded exposure and cognitive exercises that change how the brain interprets sensations. For kids with burn injuries, VR during wound care dramatically reduces reported pain. For chronic back pain or phantom limb pain, Programs that integrate movement, biofeedback, and virtual embodiment can reduce pain scores over weeks and months. The beauty of VR is that it's non-invasive and relatively accessible. In the near term, it's something you can try alongside traditional treatments, often with little downside. And unlike pills, it teaches skills: how to redirect attention, how to move without fear, how to reshape the mental map of your body. Electrical stimulation isn't new. TENS units have been sold in drugstores for decades. But what's new is the specificity. Targeted electrical pulses can nudge nerves out of abnormal patterns and toward healthier rhythms. That could mean regular external therapy sessions or implanted systems that deliver therapeutic pulses over months, encouraging the nervous system to rewire. A useful metaphor is shaking a stuck jar lid. Brief, correctly timed pulses let the system reset. Repetitive stimulation can reduce central sensitization, the amplifying of pain signals by the central nervous system, and can even promote long-term changes in neural circuits. That's why some protocols pair stimulation with physical therapy to capitalize on the brain's plasticity. Importantly, these approaches don't necessarily aim to eliminate sensation. Instead, the goal is to recalibrate, to help the nervous system understand which signals matter and which are background noise. Here's the through line. Many of these technologies share an ambitious idea. Rather than numbing everything, they work with the nervous system to restore balance. Imagine your nervous system as an orchestra where one section has been playing too loud for too long. You can't fix the problem by silencing every instrument. The symphony would be gone. The next generation of pain treatments aims to bring everyone back in tune. This approach combines several elements: precise molecular editing or drug delivery to correct hyperactive cells, implants and stimulation to adjust signaling patterns, behavioral tools like VR and therapy to reshape how the brain interprets input, and rehabilitation strategies to rebuild healthy movement and function. Together, they can change the underlying landscape that allows pain to become chronic. We can't talk about these advances without acknowledging the ethical questions. Gene editing in sensory neurons raises concerns about consent, off-target effects, and evolution of treatment-resistant pathways. Implants and neural interfaces bring privacy questions. Who owns your neural data? If devices can modulate mood or cognition, where do we draw the line? Society will need thoughtful regulation that balances innovation with safety and equity. Pain can be stubborn because it's tied into how you move, think, and live. The most promising future treatments don't try to erase pain by brute force. They teach the body new habits, correct misfiring circuits, and deliver medicine with surgeon-like precision. For people living with chronic pain, that's more than convenience. It's a chance to participate again in life without the constant background of suffering. If you've had a personal experience with any of these therapies, good, bad, or in between, share it below. These are the conversations that shape how research moves from the lab bench to real lives. So how do painkillers know where the pain is? They don't. They drift through you, quietly smoothing the rough edges of that body-mind conversation. The sharpness softens not because the ache was hunted down, but because the words between your nerves and your thoughts change. I've felt that hush settle after a dose. The buzz fades, movement returns, and you breathe easier. The body can then focus on repair. At first, you might not notice. It's in small things: shoulders unclenching, a deeper breath, patience to stand, quiet space, life returning now. Those tiny freedoms add up, and normal feels reachable again. In that quiet, balance returns, chemistry becoming comfort, science becoming peace.